Welcome to this overview of using Medicaid claims data to facilitate comprehensive program care management, provided by the UIC College of Nursing. This training will help care managers and other staff navigate and understand Medicaid claims reports, use the data to identify member risks and challenges, and recognize opportunities to manage care coordination. We will begin with an overview of Medicaid claims and how they relate to care in the comprehensive program. Claims reports are produced by the Illinois Department of Health Care and Family Services based on their records of services billed to Medicaid in Illinois. A claim is an electronic bill that is sent to Medicaid by a provider or facility. It is how providers begin the process of being paid for the services they provide. A claim includes information about the provider, the dates of service, the procedures that were provided, and the associated medical or psychiatric diagnosis. Claims data are useful for a variety of reasons. Members and their collateral supports might not accurately remember or share all of their diagnoses or treatment history. Claims data can clarify any inaccuracies in these reports and provide a rich source of historic information on the member's condition. Members may often change providers frequently, or only see a particular provider for a brief amount of time. They may not be able to remember who these providers are or what they were treated for. The records available from a member's current providers or from the nursing facility or SMRF may not be completely accurate, or might only provide the most recent information on a member's status. The only way to obtain information on the member's history may be through their Medicaid claims. Finally, information that is available from other sources needs to be verified. If the information in the Medicaid claims report contradicts other information provided, this provides a useful starting point for further assessment. Claims data also allows you to understand a member's utilization history better. Utilization history includes hospitalizations and emergency room visits, admissions to long-term care facilities, substance use disorder treatment, and the providers who have served the member. Claims can also show you a better picture of the chronicity and severity of a member's conditions. They can show you the history of a member's diagnosis, procedures they have undergone, and treatments they have received. This provides insights that are useful for service planning, including current and future care. Claims also reveal patterns in the member's history as it relates to health and utilization. These patterns can indicate underlying conditions that may not appear directly in other records. However, there are limitations to claims data. Claims reports only show services that were billed directly to Medicaid. They will not reflect services paid by Medicare, veterans benefits, or private insurance. They also may not show all claims incurred while the member was covered by Medicaid MCO or duly eligible for Medicaid Medicare. These can lead to some gaps in the information available. Claims reports are also only as accurate as the information provided by providers or facilities. Coding errors can cause incorrect information to appear in a claims report. In addition, claims sometimes have noise. This noise includes provisional or rule-out diagnoses that may later be revised when a final diagnosis is confirmed. It's important to note that there can be a delay in billing as well as claims processing. As such, there may be additional information pending when a claims report is pulled. In addition, the various sections of the claims report only lists the most recent date associated with a diagnosis, procedure, prescription, or provider. This can make connecting diagnoses with hospitalizations a challenge, especially for claims dating back more than a few years. This can also obfuscate the initial onset of a condition or show how often a particular diagnosis was billed for. Finally, the claims report available from HFS do not include any information for services received outside of the state of Illinois. This can lead to incomplete information when members have recently arrived in Illinois or who have spent periods of time elsewhere. In the comprehensive program, UIC College of Nursing coordinates obtaining claims reports from HFS. When UIC receives an assessment with a proceeding to transition outcome, they request claims from HFS. When these are received, the reports are uploaded to the web app in the Member Files and Signed Documents section. UIC will also request claims when updated claims are needed for case reviews, CAST reviews, and mortality reviews. Claims may also be requested under special circumstances, such as when a class member cannot be located or with special request from the prime. The claims report itself has a standardized structure that attempts to organize the massive amount of data contained in the claims. Please note that changes in the claims process have resulted in an update to formatting. HFS claims are now received in Excel files with separate tabs for each section and are no longer PDFs. The claims report begins with a report of the member's eligibility for Medicaid services and a chronological breakdown of the member's facility or institution visits. This is followed by lists of the member's diagnoses, prescriptions, procedures, services, and providers. Finally, the report includes the member's admission to and discharges from institutions, including nursing facilities and SMRFs. The first sheet of the Excel document includes the recipient's information, including information such as the RIN, name, birth date, and address. The second sheet reveals the list of all the members' Medicaid eligibility periods. This list will include the program the member was eligible for, including the waiver under which they may have been receiving services. It also lists the dates associated with each of these programs. These can sometimes reflect gaps in coverage. This sheet also indicates whether the member was receiving Medicaid only or was dually eligible. The Institutional Admittance tab, abbreviated in the Excel document as INST ADMIT, shows you a listing of all the hospital or emergency room visits included in the class member's claims. The first column, institution type, usually shows HOSP for hospital or LTC for long-term care. The name of the facility is also shown, but it's important to remember that facilities' names can sometimes change over time. The admission date may be blank for some claims if this information was not provided by the institution. The admission date and most recent service date will give you an approximate idea of how long the member was in the hospital or institution. For emergency room visits or outpatient services, this is generally a single day. The final column provides a brief description of the type of service received. Usually, an emergency department visit is paired to a matching outpatient services entry. Next is a list of the member's diagnoses in reverse chronological order. The first column is the diagnosis description. This may include abbreviations like NOS for not otherwise specified or NEC for not elsewhere classified. If you see diagnosis not listed, this may indicate the member's involvement with a Medicaid Managed Care Plan, or MCO. The second column includes the ICD-10 or ICD-9 diagnosis code. Note that it excludes the periods from ICD-10 codes, which can make them somewhat harder to understand. The most recent service date column indicates exactly that, the most recent date this diagnosis was billed. This does not tell you the onset of a diagnosis or even the regularity with which it has been billed. However, the final column, total diagnoses, tells you how many times this code was billed for. The diagnosis grouping section is one of the most useful portions of the claims report. In it, you can see trends like high-frequency diagnoses, those with a high number under total diagnoses in date range. Similar diagnoses, such as major depressive disorder, single episode, and major depressive disorder recurrent. Finally, it's important to know any high-risk diagnoses appearing in this list, such as cardiac conditions, respiratory disorders, or cancers. With the new Excel format, you can turn on the filter feature. With this feature, users are able to arrange data in alphabetical or numerical order by any of the columns. For example, sorting by diagnosis code results in similar codes being viewed together, while sorting by total diagnoses and range allows users to view the most frequent diagnoses together. Under the Drugs tab in the HFS Claims Excel document, you will find prescription groupings. You can see a list of a class member's historic medications filled by Medicaid. First, the name of the medication, dosage, and form. The second column includes the number of tablets or other forms dispensed in total. The Drug Code column reflects the Food and Drug Administration's National Drug Code. The most recent script date is the date that the medication was most recently dispensed to the member. As with the diagnosis grouping section, this does not show you when a medication was first prescribed. This column shows you the number of times this particular prescription was filled. Finally, the therapeutic class provides a generic description of the type of medication this is. This can be helpful in quickly seeing the types of medications a member has been prescribed. It's important to note that the medication list here is usually not current and is very rarely a complete list of the member's medications. However, this listing can provide insight into the treatments a member has tried in the past. The Procedure Groupings section is a reverse chronological list of procedures or services the member has received by billing code. The first column is a description of the procedure. This is often highly abbreviated and may not provide much detail as to what the billing code actually represents. The CPT billing code is included under Procedure Code. CPT stands for Current Procedural Terminology and is a standardized summary of the service provided to a member. If the abbreviated description is very unclear, you may need to look up the CPT code. An internet search for CPT 92014, for example, will usually give a little more information. However, the CPT is copywritten by the AMA, so full details generally require payment. The most recent procedure event is the most recent billing date. Again, this does not provide a full picture of the billing history. Lastly, the Total Procedures column shows how many times this unique code was billed. It's important to note that, as with diagnoses, similar procedures should be taken into consideration together. The next Excel tab, Provider Services, abbreviated PROV-SERV, provides another view of the services and procedures the member has received. First, we see the provider's name. This will appear as last name before first name. Next, the broad category of provider type: optometrist, physician, transportation provider, etc. The next two columns reflect the most recent billing procedure and CPT billing code by this provider. This can provide some insight into how many different providers have been providing the same type of service to the member. Finally, the most recent billing date. This is the most recent date that this unique provider billed for any service. The Provider Summary tab gives you additional information on the providers who have billed Medicaid for services for this member. The first two columns show you the provider's name, last name first again, and the provider type. Providers might include managed care organizations, transportation companies, clinics, etc., as well as individual providers. The provider address information can also provide insight into where a member has lived and also can be helpful in obtaining medical records from a particular provider. The next column shows the most recent billing date. As with all other lists, this does not show the first time a member saw this provider. And the number of service occurrences column reflects the total number of times this particular provider has billed Medicaid for any service. It doesn't tell you how many visits this shows, however, as providers can bill for multiple services in a single encounter. The Long-Term Care Admissions tab, abbreviated as LTC Admit, shows the member's long-term care or institutional admissions, such as a nursing facility or SMRF, and shows the admission date that was reported with those claims. This data is only as accurate as what was provided on the billing claims. The most recent service date does not always reflect the date the member left the facility. However, this is shown under Institutional Discharges in the next section. Under long-term care discharges, we see all of the members' reported discharges from a facility. The discharge description column shows the provider's report of where the member went, to the community, to a hospital, or to another facility, for example. This is not always accurate and relies on the information provided by the facility. The diagnosis codes listed here are the primary or secondary ICD-9 or ICD-10 codes that were provided by the facility in their billing. Now that we have reviewed the outline of a claims report, let's look in more detail about how the information in these reports can be used for care management. The basic process of interpreting the claims data for care management involves identifying and comparing information about the member's utilization, diagnoses, and condition management as reflected in the report, and using that information to provide a starting point for further information gathering and service planning. First, it's important to look at a member's utilization. Review the institutional visits, institutional admissions, and institutional discharges sections to see the member's hospitalization and long-term care history. Look at individual emergency room visits, inpatient episodes, and long-term care admissions. Compare this information with other available information, like the member's self-report, the comprehensive program assessment, and facility notes. Where there are discrepancies, request records, ask questions of the member or their supports, and work to clarify the information. Next, review the diagnosis list. You may be able to correlate some diagnoses with hospitalizations or emergency department visits. It's important to note any diagnosis that does not appear in a member's other records or self-report, and to inquire further about this. The diagnosis list can also give you insight into trends in diagnostic severity. Does a member's depression move from mild to severe, or does the intensity lessen over time? This is also the time to note any high-risk or life-threatening diagnoses, whether physical or psychiatric. These high-risk conditions and diagnoses to watch out for include suicidality or homicidality, substance use disorders or drug overdoses, diabetes, heart disease, brain injury, HIV or AIDS, any major incidents like cardiac or respiratory arrest or kidney failure, and any medical or psychiatric conditions that do not appear on the initial assessment or in other records. When reviewing the prescription report, note any high-risk medications such as opioids, benzodiazepines, blood thinners, or insulin. Also note any medications that don't appear to have a matching diagnosis. If the member has been taking insulin or blood pressure medication, it's important to understand why. The providers, services, and treatment sections can show you trends in the member's services, including the clinics and providers the member has used. These sections can also show you if the member has received specialized treatment, like radiation, dialysis, or electroconvulsive treatment, or if they have used medical transportation. The member's current or past MCO may also be shown. Again, pay attention to any claims that are linked to diagnoses that do not appear elsewhere in the member's records. Now that all of this information has been obtained from the records, what are the next steps? First, be sure to include all the relevant information from the claims in documentation related to the member's care, as appropriate. It also provides a useful starting point to ask follow-up questions of the member or their collateral supports. This can help you to clarify information about diagnoses, treatments, or hospitalizations. It's important to ask the member or their supports about the effectiveness of previous treatments, if they are no longer taking a medication, Why not? Care managers should also request records related to prior hospitalizations or emergency room visits, particularly if they are associated with high-risk diagnoses that aren't previously known. Helping members sign up for online patient portals can be helpful in obtaining some medical records, such as laboratory results, but care management staff may also need to obtain a release of information and request records directly from the provider or institution. Finally, and probably most importantly, the information contained in claims should be used to improve the member's service plan. Claims data may indicate additional referrals are required or that the member needs additional skill building to improve self-management. The member's service plan should reflect these additional needs. To provide some more concrete examples of how this information can be used, here are two case studies. The first member is a 30-year-old African American man who has lived at a nursing facility since March of 2018. He reported being admitted following a psychiatric hospitalization and denied any history of suicidal or violent behavior. The nursing facility's records indicate that the member has bipolar disorder and major depressive disorder. Here is an excerpt from this member's Medicaid Claims report. What do these claims tell you about this member? These claims show that this member visited the emergency department at Thoric on February 20th, 2019, most likely for a behavioral disturbance. These claims indicate that the member was demonstrating psychotic features in addition to bipolar disorder and has a history of multiple claims for this diagnosis. In addition, the member was recorded as experiencing suicidal ideation at the time of this hospitalization and at multiple prior interactions, despite having previously denied suicidality on the comprehensive program assessment. In addition to these psychiatric diagnoses, the billing for this visit also reflected chronic back pain. This is notable in part because of the high number of claims for this condition. Our second case study is of a 61-year-old white man. He has diagnoses of hypertension, COPD, dysphagia, liver cirrhosis, vitamin B deficiency, TBI, and hypothyroidism, as well as psychiatric diagnoses of schizoaffective disorder and severe alcohol use disorder. In the comprehensive assessment, the member reported that he was in a medically induced coma in 2012 after a fall. However, the claims report for this member do not show any hospitalization for more than 8 days between 2007 and the present, but do show emergency room visits almost monthly throughout that time. This is an excerpt from the member's claims history from Institutional Visits by Day page. It reflects the member's claims between November 2012 and February 2016. Prior to this, the member had no claims between December of 2011 and November of 2012. We can now walk through the steps of analyzing this portion of the member's claims history. Step 1 is to look at the different types of claims reflected in this member's history. The member has multiple long-term care admissions, including both nursing facilities and SMRFs. He has experienced inpatient psychiatric hospitalizations, inpatient general hospitalizations, an emergency room visit, and substance use disorder treatment. Be sure to look at the length of the stay, especially for inpatient hospitalizations or substance use disorder treatment. Next, look at the dates of services to understand the member's chronology of treatment episodes. This history tells a story that provides a significant insight into how the member's medical and psychiatric conditions have been managed and are progressing. This member's report begins with an inpatient psychiatric episode at Advocate Illinois Masonic starting on November 6, 2012, and lasting for 5 days. From there, the member went to substance use disorder treatment at LSSI for 1 month. The member had a period of no claims from December 10th, 2012 to May 3rd, 2013, when he was most likely in the community. He was then hospitalized at Stroger for 2 days and was again in the community until May 17th, 2013. He went to substance use disorder treatment at Loretto, again for 1 month. He discharged to Mado Old Town, a Smurf, on June 18th, 2013. From the Smurf, he was admitted to Methodist on October 17th, 2013 for 5 days. He then discharged to Mado Uptown, a nursing home, on October 22nd, but was transferred back to the Smurf on November 14th. We can also see an emergency room visit at Methodist on December 7th, but he returned back to the Smurf the same day. He was hospitalized at Methodist on January 10th, 2014 for 3 days. Again, he was discharged to the nursing facility, Mado Uptown, and transferred to the Smurf, Mado Old Town, on April 7th, 2014. From Mado Old Town, he was psychiatrically hospitalized at Norwegian for 5 days in May 2015, and then discharged to Atrium, a skilled nursing facility, on May 12th, 2015, where he remained until at least February 29th, 2016. Going through the hospitalizations in reverse chronological order, we can see that the member was admitted to Norwegian for an inpatient psychiatric hospitalization. The member had several psychiatric diagnoses during this encounter: schizoaffective disorder, chronic with acute exacerbation, paranoid schizophrenia, which may have been a provisional diagnosis, and suicidal ideation. The history of past noncompliance entry may also indicate that the symptoms are associated with medication refusal. Next, there was a medical hospitalization lasting 2 days at Methodist. This is an example of a situation where the primary admitting diagnosis may not be shown because this was not the most recent service date for that diagnosis. The brain injury and head injury diagnoses have appeared multiple times in the member's history, so they are unlikely to be new diagnoses from this hospitalization. The most likely acute diagnosis for this hospitalization was related to aspiration pneumonitis. The member may also have been demonstrating psychotic symptoms that did not require psychiatric hospitalization. Next, we see a single-day emergency department visit at Methodist that did not result in admission. The member returned back to the Smurf upon discharge. There are 3 respiratory system diagnoses listed with the same dates as this ER visit: hypoxemia, pulmonary collapse, and respiratory system symptoms not elsewhere classified. The member appeared to have been seen with nonspecific respiratory symptoms that resulted in a diagnosis of pulmonary collapse. This did not result in hospitalization, and the member returned home to his Smurf shortly thereafter. This hospitalization at Methodist lasted for 5 days in October 2013. The member was admitted from a Smurf, but was discharged to a nursing home afterwards, possibly indicating that his symptoms were primarily medical rather than psychiatric. This constellation of diagnoses associated with claims indicates that the member was experiencing respiratory symptoms, dehydration, and a urinary tract infection, as well as possible fever-related seizures. However, the primary diagnosis is not entirely clear without further investigation. This hospitalization at Stroger lasted for 3 days in May of 2013. The member was experiencing symptoms associated with alcohol withdrawal. He may have had dermatological conditions as well, but the details of this are unclear. Looking at this claim highlights the difficulty of interpreting claims reports that are more than a few years old, since diagnoses that are repeated later in the member's claim history would not appear here. This collection of claims is from a later period in this member's claims report. What does this particular set of claims tell you about this member? This member's claim history reflects over a dozen clusters of claims similar to this, reflecting the multiple times he has fallen while intoxicated and required medical treatment. Members may not always disclose substance use issues, and those may not always be glaringly obvious in the claims. Constellations of claims that look like this often hint at a significant substance use problem that requires further assessment. You can recognize these claims clusters by fall-related injuries, especially fractures of facial or nasal bones that are near to claims for diagnoses like altered mental status, presence of alcohol in blood, alcohol or other drug intoxication, poisoning, alcohol or other drug dependence, abuse or use disorder, or unspecified or other intoxication. Recognizing these clusters can help put appropriate supports in place to prevent relapses and monitor for recurrence of maladaptive substance use. To summarize, Medicaid claims reports can be important tools in developing a better understanding of the class member and building an effective service plan. The information contained in claims reports can help care managers identify high-risk situations before they derail a member's transition or cause critical incidents in the community. The data in claims reports is not perfect and not conclusive. It can be contradictory, confusing, and at times overwhelming. However, it provides an excellent starting point for further assessment. Claims also cannot be viewed in a vacuum. They need to be combined with the member's self-report, medical records, other collateral contacts, and care managers' clinical judgment and experience. Investigating the story contained in a claims report can take time, but it ultimately helps to ensure a safe and successful transition. The content in this presentation includes material based on scholarly research in the field of care management. For more information, please review the references listed here. Additional comprehensive program educational materials can be found on the Colbert-Williams training website, managed by the UIC College of Nursing. Any questions can be directed to the Colbert-Williams Help Desk, listed on that website. Thank you for your attention and efforts to ensure safe and successful member transitions.